Good morning, everyone. I'm Lorraine McKelvey, and I work at the University of Arkansas for Medical Sciences. I am on day 10 of a cold, so I have my water, and I apologize if I cough into the microphone. I will do my best to turn my head. It's clear to me that you know the prevalence of ACEs in our nation and in Oklahoma. I wasn't exactly sure when I put these slides together how much background you would have on this. So these are data from the National Survey of Children's Health, and they suggest that 22% of our kids in the nation have been exposed to 2 or more ACEs. In Oklahoma, 55% of your children have been exposed to 1 ACE, and 29% have been exposed to 2 ACEs. So when we think about ACEs and all that we've heard today about how ACEs and stress negatively influence development, part of what I've been thinking about is how do we take a public health approach to ACEs and screening? And so what I'm going to do today is share with you some of what we've been working on to fill some of the gaps that we think are in what we know about ACEs screening with very young children. So, as you all know, the original ACEs study was done with adult populations, retrospectively reporting on their childhoods. And when you think about how you would talk to a mother of a 6-month-old or a father of a 6-month-old about their child's ACE experience, there are definitely some considerations that we have to take into play. We can't ask the parent, the same 10 ACEs, but asking about children gives us a lot more flexibility. So what I'm going to do is talk to you a little bit about my understanding of where we are in the field in ACEs screening for young children. So the first question we set out to try to answer is, when should we screen? There's not really a lot in the literature about actual screening and the timing and frequency of screening. We know from all of the literature that we've heard today and the toxic stress literature that earlier exposures are very robust in predicting later outcomes. But if you think about being in a pediatrician's office and seeing the Bright Futures guidelines, that timetable for when we screen for particular illnesses and when we give shots, like where would ACEs fall on that timetable? So one of the things that we tried to do with data from our National Early Head Start study is see if we could learn a little bit about the patterns of exposure to ACEs over time. So in Early Head Start, we collected data from children when they were 1, 2, and 3. And we used finite mixture modeling to come up with these patterns. Thankfully, the largest group of kids was exposed to low levels of ACEs across time, and the smallest group of kids was high levels of ACEs across time. But we ended up with a relatively balanced sample of kids who had differing exposures across time. So we're high at age 1 and low at age 3, and low at age 1 and high at age 3, and a group that was high in the middle. And then what we did is take those patterns and look at the child's development at age 3. So this is a lot of data. I've kind of color-coded what's happening here. So as I said, our expectations were that the earlier ACEs would be the more robust in predicting child outcomes. And we didn't actually find that for cognitive and language outcomes. What we found was the ACE that was measured most proximally to the cognitive measure was what was most predictive. So it was the kids in the high group and the increasing group whose scores were lower than the low group and the decreasing group. And the reason we think that this is important is because if we think about ACEs and measurement of ACEs in a historical lens, the accumulation of ACEs would suggest that the patterns that change over time would have similar outcomes. They do for social emotional development. So for social emotional development, what matters is an ACE exposure at any age. So taking these data together, what we really think is if we're measuring at a later point in time, we need to measure what's happening now as well as what's happened in the past. But that these really do encourage us to think about screening on a more regular basis. So now I'm going to share a little bit about the constructs that are being measured, particularly when working with children around ACEs. This graph comes from a paper that Christy Bethel published last year, or actually maybe the year before. And really the point of showing you this is just to say that there isn't a clear consensus in the field in terms of what we call ACEs, especially when we're measuring them for children. There has been some argument in the field that the measurement, the original measurement is too narrowly defined. And when we're talking about measuring adversities that are related to development, that we should widen that focus. And so really I just wanted to say we don't really have a clear picture yet on how the ACEs construct when we're working with young children will exactly look. So now I want to talk to you a little bit about the how. With older children, there have been lots of studies of doing self-reports. There have also been some studies in the field that have used administrative data and even medical chart reviews. For the most part, most of the studies are using parent report, but how we're asking the questions about ACEs really differs across studies. So let me show you what I mean by that. The data that are collected in California in Nadine Burke-Harris's clinic, they actually use the original 10-item ACEs scale and have reworded it slightly so that the parent can report on their child's experiences. What they do is they hand the scale to the parent and they ask them to give them a number, just a total number. And while this is useful for knowing that we might need to make referrals to support the family and the child, it doesn't tell you exactly what's actionable, right? So that's one of the things that we really wanted to set forth and look at. So with the goal of effective and widespread screening, how can we ask parents of young children about behaviors that are illegal and stigmatized in a way that maintains our working alliance with them so that they maintain their relationship with us and continue to make improvements on behalf of the child? They're the conduit through which any change will happen, right? We also wanted to find information that was actionable. So when you think about one of the family ACEs is the child lived in a household with depression or mental illness or a suicide attempt. Is it important that you know that happened 5 years ago? Yes. But if you're a home visitor who's going into the household now, is it more important that you know that the mother is struggling with depression now or the father is struggling with depression now? So that's actually what we set forth to do, is to see if we could come up with a measure of ACEs using correlates of the risk and proxies for the risks that worked in the same way as the original scale. Just for the sake of time, I'm not going to go into a lot of the methodology, but I wanted you to see that we used data from about 1,300 families who enrolled in our home visiting programs in Arkansas. We did not include prenatal mothers, even though we should put together that scale. So these are families that came into services with a child born. 84% of our families were living at or below 100% of poverty. The other thing I want you to pay attention to is the fact that our kids are 33 months old on average. And then we use data that we collected at enrollment. So as part of our enrollment assessment, which we do within a month, we use a tool called the Family Map Inventories. And this was developed in partnership with Early Head Start and Head Start programs to meet the performance standards for what happens within the context of the home visit that's required by those programs. And these are a set of semi-structured interviews that measure everything we know that's related to the family and home environment and child well-being. We also screen for development using the ASQ and the ASQ-SE. So we used the family map items to come up with an ACE measure that I will say we went back and forth and thought about including additional indicators of adversity that we know are related to child outcomes. But because we were measuring ACEs in such a different way, we decided to stay as close as we could to the original 10 ACEs from the CDC. the 5 child maltreatment ACEs and the 5 kind of family dysfunction ACEs. So just to give you, oh, that cut off, I'm sorry. Just to give you a little bit of an idea about what we've done. So if you look at the physical abuse item, the original item was, did a parent or other adult in the household often or very often push, grab, slap, or throw something at you or hit you so hard that you had marks or were injured? And in the family map, we ask, in the past year, has the child been physically hurt by someone? And we consider that a risk if it's happened at least once. And we also ask if the parent disciplines the child by spanking with an object. And if they say to us they do that at all, they are considered at risk for physical abuse. We did the same thing for neglect. So if you look at emotional neglect, it's about feeling loved and special and that your family members supported one another. And we collect family cohesion in the family map, so we use items that reflect whether or not the family members feel close and support one another. And if that doesn't happen, then we consider that a risk for emotional neglect for the child. And then I alluded to this earlier, but the family dysfunction items, what we really tried to do is capture what's happening in the family now. So if you think about mental illness, was a household member depressed or mentally ill or attempted suicide, what we did is used the depression screening scale from the Patient Health Questionnaire 2, so it's whether or not there was a positive screen. And then because these are done, because these are done in the context of a home visit, the home visitor can actually tell us whether or not they observe any concern in the household. So if they go into the home and they're doing the interview and the mother says that she's having difficulties with her schizophrenia medication, she can say that that's a concern for the family. So once we put our 10-item ACEs scale together, we wanted to make sure that it was working the way we would expect with other measures of parenting. And as part of the family map inventories, we actually collect 8 items from a tool called the Piccolo, which is an observation of parent-child interaction. And these items tap affection and responsivity. We use 8 of them. So there was a significant relationship at the scale level for those items, but we also consider it a risk for warmth if the family scores, the coding is not there, barely there, and completely there, if they score in the not there and barely there for 5 items. And so families who, in our Family Map ACEs tool, had 4 or more ACEs, the odds of them being at risk in warmth was actually 8 times. They were 8 times more likely to be in that risk category. So now I'm going to show you a little bit about other measures of environmental and health risk. Just to take a second to orient you to these, because I've got 2 of these. The blue bar is families with 1 ACE compared to families with no ACEs, and the orange bar is families with 2 ACEs compared to no ACEs, and on. And so here what we see is a pretty strong linear dose response to our Family Map ACE measure and other exposures in the household that are risky for the child. So home and car safety risk includes fire risks and access to poisons and not having barriers at the top of stairs to not having a proper car seat. And as you can see, the relationship is strong and linear, and that kids in families with 4 or more ACEs, the odds are over 4 times that they're also going to experience risks in their home. We see the same thing for secondhand smoke exposure. When we look at healthcare use, what we actually see is more of a threshold response. So we ask the parent whether or not the child has a doctor that they can see when they're sick and whether or not they've had well child visits. And here we see that the odds are increased that they are not interacting in preventive health care, but they are interacting in urgent and medical care settings. And then when we look at actual child outcomes, we ask in the family map whether or not the child has a chronic condition that needs medical management. And this relationship is not as strong, but these kids are 33 months old, and we're already seeing that 4 or more of our ACE proxies is associated with the parent reporting that they have a chronic condition. It's also associated with screening at risk on the ASQ. But our strongest relationships are with social emotional development, and here again we see any adversity predicting the likelihood of scoring at risk on the ASQSE, and kids with 4 or more ACEs having 6 times the odds of screening at risk on the ASQSE. So, in summary, I think I'm out of time. We do know that we can measure ACEs very early in development in a way that is consistent with its intention, in a way that supports 2-generation programs and our working alliance with the parent. And so we're really excited about the opportunities for this. And that's it. Thank you. Just to add, thank you so much to you guys for having me, and also to all of our families in Early Head Start and our home visiting programs that have allowed us to use these data.